Good morning. I will warn you in advance, I'm going to be sharing a lot of data and statistics, and it might get a little bit dull, but try to stick with me. I'll make it as interesting as possible. I'm going to start off by sharing with you a few resources. I'm not going to go through these individually, but they will be available on the PowerPoint. If you want to learn about children, here are some places where you can go to get information about them. Child Stats, it's a government website. It's a really good, comprehensive overview of children's health issues, disease rates of various things, not just dental, but other medical conditions as well. One of my favorite websites is at the Child's Count, the Kids Count data book, the Annie E. Casey Foundation. It's got all kinds of information about children listed by state. So if you're going to practice in a particular state, you can go and find, for example, what the teen pregnancy rate is in your state, or what the poverty rate is, or a whole number of different statistics about the kids that you'll be providing care for as a pediatric dentist. The MEP survey panel is an interesting website. You can go in. It's very easy to figure out and interactive. You can, it's all about health expenditures, and there's also a parent survey that goes with it. But you can go in there and you can ask your own questions in the database. You can pull up various variables and how you want that divided up in terms of, do you want it by age or do you want it by poverty status? It's pretty easy to work with and something that you can go on and pretty intuitive where you can figure it out yourself. A couple of other databases that you can utilize. The National Oral Health Surveillance System, again, broken down by state. This is, it's a good resource because it's actually open mouth surveys, but it's not updated every year. So some of the information is as old as 1999. Okay, again, another resource for you. The CMS data for Medicaid services, states are required to submit a report each year in terms of utilization of EPSDT utilization, and that's in particular with oral health. It has to do with these specific items at this point. These are items that I pulled up for our review today. Okay, 74.1 million children in the U.S. You can see that the population of children is increasing over time. And again, the population of young children in relation to older, you can see the age 65 and older, people are living longer, so there's in the proportion of young children to older adults is decreasing. We'll be looking at a few things. Key national indicators of well-being. These are items that the government has pulled out that give a comprehensive overview of the well-being of children in this country. And they include the economic well-being, English proficiency, child injury or mortality, child maltreatment, and obesity. Again, here's another resource for you, child well-being. This was one of the databases that I pulled from quite extensively for this presentation. Economic well-being, as you can see, when you compare 2000 to 2010, the percentage of children ages 0 to 17 by family income relative to the poverty line has actually decreased in some ways, particularly if you look at the 100 to 399%, but if you look at below 100%, there's been a slight increase, and if you look at above 400%, there's been a slight decrease. Again, if you look at poverty, 1 in 5 children live below the poverty line in 2010. And just to put that in perspective, for 2013, the poverty line for a family of 4 is $23,550. So as you can imagine, 4 people in a family, that doesn't go very far. And then again, more than 2 in 5, 44%, lived in low-income families. Okay. One of the things when you're looking at income and poverty line is that it doesn't take into account government assistance to families. So a family's income, if it's 150% of the poverty level, for example, does not include those things that the government provides to them so that they can provide a little bit more for their families, such as federal tax credits, earned income credit, things like that, that actually increase their income some. Child care and housing vouchers. Oftentimes families with young children in daycare get government assistance to help pay for daycare. They also can have assistance in paying for housing. And then of course, food through the Supplemental Nutrition Assistance Program, which formerly was food stamps, and also things like specialized assistance for women and pregnant women and small children, WIC. It also doesn't reflect the variations among different regions or the cost of living in different states or towns. As you might expect, the percentage of children in low-income families is much higher for minority households, and particularly those households that are headed by a single female parent, as opposed to a Caucasian married couple, which you can see is the lowest percentage living in poverty. Children in single-parent families, again, as you'll recall, higher percentage of children in single-parent families living below the poverty line than in two-parent families, and you can see how that's broken down by ethnicity. Food insecurity, this might be something you've heard about previously. It really has to do with the ability of a family to put food on the table. And that may mean that they can't afford to purchase food, or it may mean that nutritious food is not available in their particular community or neighborhood. In the United States, food insecurity is primarily related to poverty. So you can see 22% of children lived in households where food was insecure. That's amazingly similar to the percentage of children living in families below the poverty line. There are some, again, federal programs, supplemental nutrition, the school lunch program where children can get free nutritious meals at school, including breakfast and lunch, and then also the WIC program for pregnant women and young children. English proficiency and racial diversity. In this country, as you can see, white, Caucasian is very rapidly becoming a minority. If you look at the growth in populations of different minorities, you can see that Hispanic population is growing quite rapidly in this country. And again, think about those families living in poverty and which groups had more children raised in families below the poverty level. And this has great implications, for the future in terms of low-income families, families that are receiving Medicaid or other types of assistance. In this country, in 2010, 23% of children lived with at least one foreign-born parent. 21% of children lived in a household where English was not the language that was spoken, and of those, about 5% of these children have difficulty understanding English. Child injury and mortality. These are some, I think, interesting data, and particularly related to child abuse and maltreatment. If you look at the emergency department visits for children, the most frequent is a fall, but second is having been struck. And when you look at the total lifetime costs of injuries of children are over $50 billion. Child maltreatment. Most children who are maltreated are between the ages of 0 and 10. If you look at across the country, you can see that the child maltreatment rate varies by state from a low of 21% to a high of 45% of children having had some form of child maltreatment. Just think about that for a second. Almost half the children in some of these states have been maltreated, either through child abuse or through some other form. Maltreated children account for 38% of Medicaid spending, even though they're a much smaller percentage of the Medicaid population. Average cost per year for a child who's been a victim of child abuse is a little over $4,000 compared to a little over $1,000 for a child who has not been a victim. This is primarily because of mental health costs and other costs associated with psychological counseling and other services. Again, more information about the foster children and the cost to Medicaid. Now, moving on to something a little more pertinent to provision of dental care, you can see that we'll be talking about some health insurance sources, dental visits, untreated caries, and the perceived need for dental services, which I think as we get a little closer, I'll explain why perceived need is a really important topic to think about and look at in terms of parent education and health literacy. If you look at the relationship between poverty and health insurance, you'll see that children without health insurance primarily are below 200% of the poverty level, but there are a few children above that. Most children below the poverty level qualify for some form of Medicaid. However, there are children who do not qualify for Medicaid services, or their parents choose not to participate in the Medicaid system for various reasons. A breakdown of insurance for children, all children, not just children below poverty, but all children. And you can see that most children are covered by employer-provided health insurance. About 31% of children are covered by some sort of public insurance, which would include Medicaid or CHIP. Dental visits. There are a lot of statistics out there related to the number of dental visits or the percentage of dental visits that children get, and you really have to look carefully at the information source because they obtain that information in different ways, and depending on how that information was collected, you get very different results. So, how was it collected? Who was it collected from? Was it a question that was asked of a parent, or was it claims data that was reviewed to obtain the information? And as you can see, America's children, you can see that the wide variation. If you look at the MEPS data, which is based on expenditures, you can see that for low-income children, it's about a little over, almost 37%. High-income children, about 64%. However, if you look at National Survey of Children's Health, which was a parent survey, you can see that 72% of low-income families reported having seen a dentist. However, we'll go over these different sources, and you can see that having a dental visit, not only is it a difference in who is asked the question and how it is asked, but an actual dental visit is defined differently in different databases. So percentage of children 2 to 17 with a dental visit in the past year. This is America's children, and it's the question that was asked was, how long has it been since your child last saw or talked to a dentist? Which, if you're asking a parent that, what does that mean? We talked to a dentist. Oh, I saw a dentist at the grocery store the other day. Who knows? And you can see that the report is fairly high in terms of the percent that I've seen, particularly if you look at the age 5 to 11 age group. Oh, the other piece of that is the definition of dentist for this was dentist, orthodontist, oral surgeon, all other dental specialists, and dental hygienists. Okay, the medical expenditure, once again, that is looking at actual expenditures related to medical procedures, and it goes beyond dental. So only a subset is dental, but I pulled out the dental information for you, and you can see those percentages there. Dental visits by race, total, this is again from the MAPS data, total is about almost 50%, whereas if you're looking at different ethnicities, you can see, once again, white, non-Hispanic, the highest percentage who had reported a dental visit. Okay. This is a survey of children's health. The question again, during the last 12 months, or since your child's birth, if they're less than 1 year of age, how many times did your child see a dentist for preventive dental care, such as checkups or dental cleaning? So the question, much more specific in this case, however, still get a fairly high percentage. If you're looking at publicly insured, 73.5% of kids, and we could see from the CMS 416 data, much lower percentage had actually had dental claims related to receiving any type of dental care. Again, you get a huge variation depending on state. So this is something, and the data is available state by state basis. I'm reporting the national data, but if you're interested in your state, you can always go to the data source and pull up for your specific state. Percentage receiving varying from anywhere from 62% all the way down to a low of 23%. Unmet dental needs, again, okay, we look at the difference. This is parents who've reported that they didn't get the dental care that they need in some cases. So survey of dental health, the question was asked, has your child gotten all the dental care that they needed? Only 5.4% of parents reported that they had not. If you look at some of the other data sources, you can see that it's a much higher rate, and particularly the NHANES data, almost 20% of children had not received all their dental needs. Okay. Some more data related to similar information that was summarized on the previous slide. As you might expect, uninsured children were much more likely to have unmet dental needs than children with insurance. And then again, non-Hispanic, more likely to have their dental needs met than Hispanic or non-Hispanic Black children. Okay, a breakdown of prevalence of untreated dental caries. Put this into the context of when parents were asked, have you had all your dental needs met? Only 5% said no. However, if you look at untreated dental caries for children below 100% of the federal poverty line, you're seeing well over 20%, 25, 24, 20, depending on the particular age. So a real paradox there in terms of parents' perception and what's actually seen when you look inside a child's mouth and see what has been treated and what has not. Again, untreated dental caries, broken down a little bit differently. This is all children grouped together, and you see a variation of 10% to 21.5%. National Oral Health Surveillance System. Again, these were open mouth surveys that were conducted at the state level. Not every state did them, but most states did. Really good data in terms of accuracy in what was reflected for third graders. However, again, an in-mouth survey is very expensive, and states cannot afford to do that every year. The date of the information that was provided varies greatly from 99 to 2011. There have been many changes in the system, many differences between that. You just can't compare 99 to 2011 very well. However, it does give an idea of what was happening in the states at that given date and time. And you can see, again, wide variation from one state to another. Okay, here we go with the perception of need, and it just depends on who you're asking and what you're asking. So in this particular one, most parents said 91.7% of 0 to 5-year-old children said their child did not need any dental care. When you ask parents if they were not able to get dental care, this is what the information you get for 0 to 5-year-olds, 0 to 4-year-olds. 2.3% of parents said they were unable to access care. But when you look at untreated caries, you see that 14.4% of children between the ages of 3 to 5 had untreated caries. So you have to ask the question again, are we talking about access or utilization? Is care available? If parents aren't seeking care, we really don't know if there's available care for every child who needs it. So this really speaks to the need to educate families about the importance of primary teeth and why they need to see a dentist at an early age. Again, access versus utilization. And just to put that in context, according to our federal government, nearly half of American adults have difficulty understanding or acting upon health information. So you're looking at half of our adult population really not being very literate and health literate. So it's on us as professionals to help them understand the healthcare system and the need for treatment and what is available and how they can access and utilize that information. Okay, AAPD obviously believes that every child deserves a healthy start in life. And we also understand that children from low-income families do have higher rates of care and more difficulty accessing that care. However, we feel our dental membership is really stepping up to try to fill that need. We recently did a survey. We've developed a representative cohort sample, and we're working with the American Dental Association to conduct several surveys to assess key questions that we have amongst our membership of what's happening and how our members are providing service. The first survey that we did was related to case management and serving low-income families. And we found out that approximately 82% of our members do provide different payment options, whether that's a sliding fee scale or the ability to make payments or some other type of financing. 44% assist families in filling out Medicaid paperwork. 27% provide information about transportation, and 24% coordinate with community services. These are services like home visiting programs, WIC, Head Start centers, in order to both educate families and also to help families help their children get the care that they need. Most of our members conduct caries risk assessments, and I know you'll hear a little bit more about that later. And the most popular risk assessment that our members use is the AAPD caries risk assessment tool, which is no surprise. Okay, pediatric dentists communicate with families. 96% tailor their information to the family's literacy level or the family's, the patient risk level, which is outstanding. And I think it's a necessity given the variations in health literacy, given the variations in the ability to speak the English language and other variables. Over half use motivational interviewing. How many of you have heard of motivational interviewing? Okay, just a couple. What motivational interviewing is a way of talking with families where you're not telling them what to do, but you're engaging them in a conversation and helping them to identify their own goals and their own challenges, as well as assisting them in coming up with ways in which they can overcome some of those challenges. So for example, instead of telling a parent that they have to take their child to the dentist, if you're out in the community, you might ask the parent what their goals are related to their child's oral health. And you might get, what? What do you mean goals related to oral health? Well, do you want your child to have healthy mouth, healthy teeth? And they'll say yes. Do you know how to do that? And they may or may not know. So you're letting the parent guide that process and come up with their own solutions as opposed to telling them what to do. And it's really encouraging that over half of our members are doing that because they see a need for that in the children, and that's, you know, because of many of the statistics that I showed you previously. 67% use interpreters. Again, think back to the number of children living in families where English is not the first language, and you see that that's a necessity in today's world. Another way of meeting families where they're at, or helping them to overcome some of the challenges related to low health literacy or lack of access, is to offer services in the community, and many of our members are doing that. Over 80% of our members go out into the community to provide patient education. 51% do screening in places like schools or public health clinics. 45% do referral to other types of organizations. And let's see, I can't read this. Oh, only 13% do no services out in other community settings. One way of overcoming the parental lack of information on the importance of early oral care is for primary care physicians, such as pediatricians or family practice doctors, to inform families about the need for good oral health and good oral habits, the need for an early dental visit. According to one survey, you can see that in 2008, less than half of the children between 2 and 17 were offered advice from a healthcare provider for the need for checkups. And again, if you look at uninsured children, only 34% were told to see a dentist, which really speaks to the need for us to collaborate with our medical partners out in the community. It is part of the AAPD policy that they include dental care as part of their well-child visits. However, in 2009, only 50% of pediatricians actually address even toothbrushing in a well-child care visit. Again, back to, I want to leave you with the idea of accessing your own state's information, because everything varies so much by state. And you can see here just an overview of the country. The Casey Foundation does a rating of each state and how it fits with all of the variables, and you can see where the states rank. I do want to mention, Bert told me right before the presentation, if you take a look at today's New York Times, you'll see some information about high school graduates. And one of the stats that they report that really stands out is that 71% of 18-year-olds in this country have been some sort of victim of assault. I'll leave you with that and encourage you to look at the article itself. Does anyone have any questions? Oh, okay, sure.
Nicholas from Silverman.
Hi, Nicholas.
Hello. I guess one of the things I find interesting, I guess this is more anecdotal, that when the parents do come in and we say, oh, if you have a 1-year-old, you should come in at 1 year old, because they're bringing a 3-year-old. And they said, I've never heard it before. My physician told me to bring my child when he's 3. And I feel like it's a consistent, so even though if the pediatrician is speaking to the parents, sometimes it may be even incorrect, because we see them at 3 and then they mouthful of cavities, unfortunately.
Yeah, the point was made that oftentimes when a 3-year-old comes in and a parent will say they didn't know they were supposed to come in at 1. And we hear that all the time. And I think, the Academy has really put a lot of effort into the age 1 visit and advertising the age 1 visit and the importance of early care. I'll throw out to you the cost of care if a child comes in at 1 versus age 5 is less than half for the first 5 years. So something to keep in mind. Yes?
Fred Adams from Stony Brook. I think that something that the Academy should also do is to meld the data that's coming out about kids who are using emergency rooms as their first visit. Mm-hmm. We at Stony Brook, one of our residents who's not here, has done a study in which she's looked at the prevalence and even repeat offenders of kids presenting to our dental ED for their first visit. And of course, it's subsequent to a problem with a parent, that is, the kid's in pain. Mm-hmm. And a percentage of those kids having to be admitted and what the cost outcome of that is. So I think you guys could meld that in, because that really goes into the issue of maltreatment and neglect, because these kids are presenting with obvious problems. This is not a question if they have problems. Anybody could look in their mouth and say there's something really wrong here.
Thank you for making that point. And that's a great point. The Policy Center of the AAPD is putting out a policy brief within the next few months specifically related to the age 1 visit, and we will be tying that into emergency care. One challenge that we found is the study out of North Carolina that looked at the cost of care over the first 5 years related to the age of the first dental visit. One of the reasons why the cost was so much less with the early visit was that they did look at the medical costs as well, including both emergency room care and the cost of providing general anesthesia. However, some studies have looked at the cost of care and not found that relationship, specifically because they don't pull the medical costs out. So this is something that we feel really requires more education in the field, and certainly we want to encourage parents to get care before their child's in pain, for not just for economic reasons, but for human reasons as well.
Jan, why do we think that twice as many parents say they took their child to the dentist than the evidence suggests they did? What are some of those? Do they really believe they did, or are they trying to be polite?
Well, I think that it has to do with the interpretation of the question. There were two different questions asked. One had to do with if your child needed care, were you able to access care, or did you access care? And if parents don't know their child needs care at an early age, they're gonna say, oh no, I had no problem seeing a dentist. I did see a dentist when I needed care. The other question, has your child seen or talked to a dentist, I think requires parents to remember. And I gotta tell you, I don't remember the date of my children's last dental visit. I know that they go twice a year and we get the appointment reminders, but particularly in some of these families, it's very chaotic. They have a lot of different challenges, a lot of economic challenges, a lot of, if you're having a hard time keeping a roof over your head, are you really going to pay that much attention to the date that your child last went to the dentist? So I think you're asking parents to remember something that A, isn't a priority for them, and B, can easily be lost in the milieu of all the different needs that family has.
Thank you.
Thank you.